Dear students, today we continue lecture about neonatology problem. And today lecture is devoted to bacterial infection of newborn, neonatal sepsis. What is mean neonatal sepsis? Neonatal sepsis or sepsis neonatorum or neonatal septicemia are terms that have been used to describe systemic response to infection in neonatal period. But before beginning lecture, I would like to remind you once again about textbook EUM Slack with theoretical material of pediatrics and task with correct answer, explanation, correct answer, and with explanation and correct answer. This material help you to prepare for exam with correct task. Okay, now we continue discuss about sepsis in neonatal period. Sepsis is defined as systemic inflammatory response syndrome, SIR syndrome, resulting from suspected or proven infection. I think you remember what it means systemic inflammatory response syndrome from surgery course, because in adults SIRS characterize fever or hypothermia, tachycardia, tachypnea, abnormal white blood cells. What it means SIRS in neonatal period? In neonatal period, systemic inflammatory response syndrome include temperature instability, respiratory dysfunction, cardiac dysfunction, perfusion abnormalities. Now we detailize what is mean systemic inflammatory response syndrome in neonatal period. Temperature instability. When you reveal in newborn temperature less than 36 or more than 38.5. Respiratory dysfunction. When you reveal in newborn tachypnea. When respiratory rate more than 2 standard deviation above the mean for the age. Or hypoxemia, when indexes of partial pressure less than 70. Next, cardiac dysfunction. When you reveal in newborn tachycardia, delayed capillary refill more than 3 seconds, and signs hypotension. When high pressure, blood pressure more than 2 standard deviation below the mean for the age. And perfusion abnormality. When you reveal in newborn oliguria, urine output less than 0.2 milliliters per kilogram per hour, or signs lactate acidosis when pH less than 7.25 and altered mental status. Neonatal sepsis is a clinical syndrome of systemic illness accompanied by bacteremia occurring in the first months of life. What does mean clinical syndrome systemic illness? A serious systemic illness in the neonatal period may be caused by perinatal asphyxia. I think you remember last lecture about severe asphyxia. Next, respiratory tract disorder, for example, syndrome meconium aspiration, severe aspiration pneumonia. Cardiac disease, congenital or acquired cardiac disease. Metabolic disease include hypoglycemia, congenital adrenal hyperplasia, organic acidosis, urea cycle disorder. Neurologic disease include intracranial hemorrhage and other disease of neurologic of nervous system. Hematologic disease include neonatal purpura fulminant disease or severe anemia, methemoglobinemia, congenital leukemia. Epidemiology of neonatal sepsis. Among the 6 million of all deaths in children under the 5 year, 45% died in the neonatal period. About half percent of patients. Next, neonatal sepsis is said the most common cause of death in this group. The vast majority of which are in the developing country, including Ukrainian. Neonatal sepsis is common in premature infants. Sepsis in term infants is serious, occurring less than 1%. In this slide, you can see incidence of mortality, neonatal sepsis in preterm infants. And in this slide, we can see the very high mortality, about 50% in newborn with weight less than 750 grams. Extremely preterm newborn. We can see that about 40% of mortality in newborn less than 1 kilogram, and about more than 30% of mortality in newborn less than 1,500 grams. In this slide, we can see epidemiology of the late onset sepsis. The same, we can see the very high mortality in newborn with low base weight, extremely low base weight, less than 1,000 grams, about 65, 55, 51, 32% mortality in this kind of patient. Neonatal sepsis is common in premature infants, you can see on the previous slide, but the most important neonatal factor predisposing to infection is the prematurity and low birth weight. But I would like what your opinion about why in this kind of patient very high percent of mortality. Firstly, I think you know that very important anamnesis, very important infection in mother. Maternal genital tract infection is important cause of preterm labor with increased risk of vertical transmission to newborn. Infection lead to the increased synthesis of prostaglandin, activate macrophage and cytokines, interleukins, and interleukins stimulate prostaglandin synthesis and cytokines release. And release of cytokines lead to the rupture of membrane. Next, very important reasons that lead to the neonatal sepsis in premature infants, immature dysfunction. Next, premature infants often require prolonged invasive procedures, such as intravenous access and endotracheal intubation that impair barrier and clearance mechanism. Now we discuss about classification of neonatal sepsis. Neonatal sepsis is a blood infection that occurs in infants younger than 90 days of old. And neonatal sepsis divided in few groups, 3 groups. Early onset sepsis from birth to 72 hours of life. Late onset sepsis more than 72 hours of age to 90 days, and nosocomial sepsis. Now we detailize what it means, what etiologic agent, what clinical signs, early onset sepsis. Early onset sepsis presents in the first 2 weeks of life and is usually a multi-system fulminant illness with prominent respiratory symptoms. Early onset sepsis is characterized by sudden onset and a fulminant cause that can progress rapidly to septic shock with a high mortality rate. All the main risk factors of the early onset sepsis: maternal group B streptococcal infection, colonization, bacteriuria, prelabor rupture of membrane more than 18 hours, signs of corium neonitis, when you can reveal in mother in the antenatal period before delivery, high fever, more than 38 plus maternal leukocytosis more than 15,000, fetal tachycardia more than 160 per minute, uterine tenderness, and foul smelling amniotic fluid. Next, very important information about antibiotic therapy before labor. Parenteral antibiotic treatment given to women for confirmed or suspected invasive bacterial infection during labor or in the 24 hours period before or after birth. It's very important factors for develop early onset sepsis. In the slide, we can see a difference between early onset sepsis and late onset sepsis. What difference you can see? Firstly, timing. Early onset sepsis appear less than 32-96 hours. The main causative agent, gram-negative flora. The main origin, maternal. Diagnostic markers is variability and mortality very high and prevention associated with the mother. Late onset sepsis. The late onset sepsis is common after first 2 weeks of life. Also, these infants may have a history of obstetric complication, and these infants usually have identifiable focus and most often meningitis in addition to sepsis. Nosocomial or hospital-acquired sepsis is responsible for significant morbidity and late mortality in hospitalized newborns. Nosocomial infection in newborn occurring after 3 days of life in hospital, very important in hospital, that are not directly acquired from the mother's genital tract. Premature infants have an increased susceptibility to infection because of underlying illnesses and immature immune defense we discussed. What are the main risk factors for nosocomial infection? Firstly, prematurity. Prematurity and low birth weight. Newborn with low birth weight, extremely low birth weight. Next, invasive procedures. Indwelling vascular catheter, prolonged parenteral nutrition, endotracheal tube or ventricular shunt, patient with hydrocephalus, frequent use of broad-spectrum antibiotics, prolonged time, prolonged hospital stay in intensive care or hospital, and alteration of the skin or mucous membrane barriers. In this slide, we can see the risk factors that lead to the nosocomial infection. Prolonged time of umbilical catheter that lead to the disorder of mucus and the skin barrier. Next, patient with intensive care with a lot of invasive procedures. Catheter, zonde, and endotracheal tube. Next, in this slide, we can see the same infection associated with the catheter, central or peripheral. The most frequent nosocomial infection are the bloodstream infection associated with the intravascular catheter, and such as we can see necrosis after intravenous catheter. Next, and pneumonia, especially ventilator-associated pneumonia. Next, very important information about biofilms of microorganisms. In this slide, we can see fungal biofilms. In the patient, in patient who had a lot of invasive procedures, such as intravenous catheter, sometimes develops biofilm in these intravenous devices. And these biofilms may be a main cause that lead to the disseminate infection and activate bloodstream infection. Predisposing risk factors of sepsis in a newborn include resuscitation at birth, infant who has fetal distress, airborne traumatic delivery, or were severe depressed at birth and require intubation and resuscitation. This group patients have a very high risk of neonatal sepsis, such as nosocomial. Next, medical intervention, invasive procedures, vascular access, endotracheal intubation, parenteral nutrition, intrauterine monitoring, pressure catheter or scalp electrodes is the same. Invasive procedures lead to the nosocomial infection. And very important about male sex. Male are 4 times more affected than female in this kind of patients. Sepsis and meningitis more common in males. I think you understand. The prematurity is a high risk factors of both early onset sepsis and late onset sepsis. What the main etiologic agent of sepsis? First group, bacteria infection. Group B, streptococci, Escherichia coli, Listeria, negative Staphylococcus, Treponema pallidum. Next, viral infection, maybe herpetic infection, enterovirus infection, cytomegalovirus infection, fungi, very often candida, and maybe protozoous infection. Now we discuss about etiologic agent of early onset sepsis. The main cause of early onset sepsis, bacteria group B, streptococci, plus Escherichia coli, about 60 to 70 of infection, Klebsiella, and maybe Listeria, monocytogenesis gram-positive bacteria, Staphylococcus aureus, and group A, streptococci. In this slide, we can see the main etiologic agent of early onset sepsis, and we can see that group B streptococcus and the Escherichia coli is the main etiologic agent of early onset sepsis, about more than 80%. Next, we can see in this slide, we can see etiologic agent in a different kind sepsis. For example, in early onset sepsis, the TPA less than 72 hours, the main etiologic agent include Escherichia coli, group B streptococcus, coagulation negative staphylococcus, and Haemophilus influenza. Late onset sepsis that appear more than 72 hours. The main etiologic agent is the first place coagulation negative Staphylococcus aureus, Candida, and Escherichia coli. And very late onset sepsis appears more than 60 days that may be associated this infection. Etiologic agent of the late onset sepsis. When appear sepsis that appear more than 72 hours. The main etiologic agent Staphylococcus aureus, Staphylococcus epidermidis, plus gram-negative flora, Pseudomonas, Serratia, Klebsiella, And very important information about the etiological agent of late onset sepsis in extremely and low birth weight infants. First place, Candida and the coagulation-negative Staphylococcus. In this slide, we can see which organism causing late onset sepsis in intensive care in different countries. And we can see different countries, USA, Australia, Korea, Germany, Asia, Turkey, Mexico. And we can see the very common, often etiological agent, coagulation negative Staphylococcus, Staphylococcus aureus, Escherichia coli, Klebsiella, Pseudomonas, and the Candida. Now we discuss about clinical signs of neonatal sepsis. But I would like that you know the clinical signs of neonatal sepsis are non-specific because very important, very subtle signs. Clinical signs associated with characteristic of the causative organism and the body response to invasive. These non-specific clinical signs in early onset sepsis associated with different disease in neonatal period, such as respiratory distress syndrome, metabolic disease, intracranial hemorrhage, and traumatic delivery. Now we can see what the main signs of neonatal sepsis. Neonatal sepsis can be defined by presence of at least two clinical symptoms and at least two laboratory signs in the presence or as a result of suspect or proven infection, positive culture, microscopy, polymerism change reaction. In this slide, we can see clinical signs and laboratory signs that you can reveal in newborn with sepsis. Clinical, now we detailize this, clinical signs and laboratory signs. Clinical signs include modified body temperature, temperature greater than 38.5 or less than 36, and temperature instability. Cardiovascular instability, when you reveal bradycardia, tachycardia, or disorder of rhythm stability, reduce urine output less than 1 or 0.5 milliliters per kilogram per hour, signs hypertension, and disorder of skin, mottled skin, impaired peripheral perfusion. Skin and subcutaneous lesion characterize disorder of skin, mottled skin, petechia, rash, scleroderma, acrocyanosis, cyanosis. Respiratory instability include respiratory disorder such as apnea or tachypnea, increased oxygen requirement or requirement for ventilation support. Next, disorder of gastrointestinal tract, feeding intolerance, poor sake, abdominal distension. And very often non-specific signs characterize irritability, lassity, or hypotonia. Laboratory signs. What laboratory signs indicate and that you can suspect sepsis when you reveal increase or decrease white blood cells, less than 4,000 or more than 20,000. Immature to total neutrophil ratio greater than 0.2. Next, in the quantity of platelets less than 100,000. Next, C-reactive protein. Increase indexes of C-reactive protein more than 15 and very important procalcitonin more than 2 nanogram per milliliter. Glucose intolerance. Sometimes you can reveal hyperglycemia when blood glucose more than 10 millimole per liter or 180 milligram per deciliter, or hypoglycemia when blood glucose less than 2.5 millimole per liter. And the signs metabolic acidosis. I think you remember about metabolic acidosis from previous lecture when you reveal very high indexes of base excess, more than 10, and increases serum lactate. What clinical signs of early onset sepsis? Non-specific, but you can reveal tachypnea, respiratory distress, apnea, tachycardia or bradycardia, poor peripheral perfusion when capillary refill time more than 3 seconds, mottling of skin, temperature instability, hypothermia or hypothermia, disorder of nervous system, lassity, irritability, altered muscle tone or floppiness, and disorder of gastrointestinal tract, vomiting, poor feeding, intolerance. Next, a very important disorder of nervous system. Balding fontanelle is a very late sign in neonatal meningitis, and Brudzinski sign and Kernig signs is really found in neonatal period. I would like that you remember this information. Next, the presentation include maybe irritability, vomiting, poor feeding, disorder of temperature, or lethargy, apnea, spells, disorder, metabolic disorder, hypoglycemia. Next, sometimes appeared change of behavior, lethargy, irritability, change, muscle tone, problem of feeding intolerance, vomiting, diarrhea, when you reveal watery loose stool, abdominal distension with or without visible bowel loops. You can see in our patient in distension abdomen and indicate enlargement of liver in patient. Disorder of skin, we can see that jaundice, sometimes rash, petechia, mottling, cyanosis, patient with jaundice, specific signs of mottling. Cardiopulmonary disorder, tachypnea, respiratory distress, grunting, flaring, retraction, apnea within the first 24 hours of birth, or when it be a new onset, especially after 1 week of life. Tachycardia, hypertension, and in this picture, we can see a patient with jaundice, mottling, and distension abdomen, lassity. Main signs of sepsis, late signs include respiratory failure and signs of pulmonary hypertension. Sometimes appear clinical signs of septic shock, adrenal hemorrhage with adrenal insufficiency, signs of cardiac and renal failure, liver disease with hyperbilirubinemia and elevated enzymes, disorder of hemostasis, prolonged prothrombin time and partial thromboplastin time. Bone marrow failure when you reveal neutropenia, thrombocytopenia, anemia, and the signs of disseminated intravascular coagulation. Now we discuss about confirmation of neonatal sepsis. When there is a multi-system involvement or when the cardiorespiratory signs are consistent with a very severe illness, sepsis should be considered in this case. The initial presentation may be limited to only one sepsis, but when you reveal apnea, tachypnea with retraction, tachycardia, in this case you can confirm laboratory signs, confirm diagnosis neonatal sepsis. Laboratory evaluation for neonatal sepsis should include CBC analysis. So what you reveal in CBC analysis, neutropenia or elevated ratio of immature to total neutrophils, thrombocytopenia, or increased ESR. Next, very important index is selective protein, interleukin 6, procalcitonin. Next, a very important culture examination, bacteriological examination, culture of blood, urine, and other sites. Lumbar puncture, when you reveal clinical signs of neonatal sepsis and disorder of nervous system, lassity or hyperalertness, seizures. In this case, very important examine spinal fluid because very important examination lumbar puncture when you reveal cells count, protein, glucose culture. Chest radiograph and the gram stain and culture of fecal aspiration if the infant is intubated. In this slide, we can see is a very important markers of neonatal sepsis. And we can see during the first few hours, very important indexes, interleukin 6, interleukins 2, interleukins 8, and tumor necrotic factors. After 12 hours of disease, we can see increase procalcitonin. And after 24 hours, we can reveal increase C-reactive protein. Now we discuss about evidence of indexes that indicates infection. Evidence of infection, evidence of inflammation, and evidence of multi-organ system disease. Evidence of infection. What help confirm of infection in organism? Culture of normally sterilized site. Culture of blood, CSF, and others. Endotracheal, from endotracheal tube, urine. Next, very important, antigen detection, urine or CSF. Maternal or neonatal serology, when you want confirm specific infection, syphilis, for example, toxoplasmosis, or different viral infection. And in a very bad prognosis, patient with very bad prognosis, autopsy. Next, evidence of inflammation. What indicates about inflammation process? CBC analysis, leukocytosis, hematocrit, total neutrophils count ratio, C-reactive protein, procalcitonin, cytokines, interleukin 6, placentosis in CSF, cerebrospinal fluid, or synovial fluid, or pleural fluid, and disseminate intravascular coagulation, fibrin split products. Next, evidence of multi-organ system disease, multiply dysfunction, include metabolic acidosis, when you reveal pH, or partial dioxide, pulmonary function, when you reveal disorder of renal function, increased bune or creatinine, when you reveal signs that indicates about hepatic injury, increased bilirubin, increased enzymes, ammonia, and PT, and prothrombin time. Bone marrow function, neutropenia, anemia, or thrombocytopenia. Diagnostic criteria of sepsis, when you reveal general variables, when you reveal temperature instability, tachycardia, tachypnea, altered mental status, and the significant edema. Inflammatory variables, when you reveal leukocytosis or leukopenia, increase the more than 10% immature form, C-reactive protein, and procalcitonin. Next, hemodynamic disorder, when you reveal hypertension, tissue perfusion variables, when you reveal hyperlactatemia and decreased capillary refill. Organ dysfunction include hypoxemia, oliguria, increased creatinine, coagulation abnormalities, thrombocytopenia, and hyperbilirubinemia. Next, you must remember about different diseases that characterize similar signs, such as Respiratory distress syndrome characterizes severe respiratory disorder, metabolic disease, hematologic disease, disorder of the nervous system, cardiac disease, and other infections such as specific infection, torch infection. And in this case, you must do differentiate diagnosis between the different diseases. Now I would like to discuss management of neonates with suspect or proven early onset sepsis. Very important risk factors. When you know specific risk factors, corium neonitis or premature rupture of membranes more than 18 hours, or when mother using antibiotics during pregnancy or during delivery. Risk factors. Next, when you have risk factors, you recommend specific diagnostic tests. Include blood culture for the past, next white blood cells, calculate and differentiate immature form, selective protein, and other specific markers, interleukin, tumor necrotic factors, or procalcitonin. In this case, when you know risk factors and a positive diagnostic test, recommended antibiotics treatment. And after that, you manage. You must now management according to result of examination. When you reveal positive blood culture and you have specific risk factors and positive blood culture plus clinical signs. In this case, you recommended antibiotic therapy and recommended lumbar puncture for exclude neonatal meningitis. Next, when you have clinical signs, risk factors, but blood culture negative, infants remains well, but abnormal laboratory test, diagnostic test. In this case, you continue antibiotics. If you know information, the mother received antibiotics during labor and delivery. And next, when you have a patient with risk factors, clinical signs, and patient with negative blood culture, and the condition patient is good without clinical signs of infection, and our diagnostic test negative, in this case, doctor can discontinue antibiotics therapy. What we must know about antibiotic therapy? The standard empiric therapy is aminoglycosides, amikacin or gentamicin, combined with amoxicillin. You must remember about cephalosporin. Cephalosporin should be avoided the first line therapy because of the high risk of developing resistance and should be resistant in the special case. What about standard empiric therapy? You recommended gentamicin in dose at 4-5 mg per kilogram per dose, or amikacin 15 mg per kilogram per dose intravenous every 24 hours, and amoxicillin in dose at 50-100 mg per kilogram per day, intravenous every 12 hours. Next, very important information about antibiotic therapy. As clinical and laboratory signs of neonatal infection are non-specific and the symptomatic neonates are treated empirically with antibiotics, in this case, very important to reevaluate the need for continued antibiotic therapy after 24 hours. And after that, we can recommended continue or discontinue antibiotic therapy. In the most cases, based on the clinical cause, negative culture result, and laboratory parameters, a decision can be made to stop safely antibiotic therapy. Next day, you must remember the prolonged antibiotic therapy, more than 5 days, causes increased mortality and high incidence of necrotizing enterocolitis in preterm infants, emphasizes to the need to stop empirical antibiotic therapy in the absence of proven infection. When negative culture, acute phase rectans negative, as early as possible, and latest after 48 and 72 hours. We can see recommendation antibiotics treatment for sepsis in neonatal period and infants. And according to this recommendation, antibiotic therapy for early onset sepsis, ampicillin, gentamicin, nosocomial sepsis, vancomycin and gentamicin, or vancomycin and meropenem, or vancomycin and cefotaxime. And you must remember about change antibiotic therapy based on the culture sensitive. According to different guidelines, NICE guidelines, or American Academy of Pediatrics and British medical journals according to World Health Organization recommendation for early onset neonatal sepsis, recommended the use of benzyl penicillin or ampicillin combined with gentamicin as empiric treatment, at the least third generation cephalosporin as alternative. Empiric therapy, I think you remember, we recommended ampicillin or 50 milligram per kilogram per day to 100 milligram per kilogram is the case meningitis intravenous plus gentamicin 5-7 milligrams per kilogram. Next, depend on the cause. For example, when you know about Staphylococcus aureus infection or methicillin Staphylococcus aureus infection, in this case, recommended vancomycin. Next, general guidelines include ampicillin, cefotaxime, ampicillin, gentamicin. According to the NICE guidelines, neonates with suspected sepsis during the first 72 hours recommended intravenous benzyl penicillin with gentamicin, minimum 7 days intravenous, and neonates with community-acquired sepsis, in this case recommended newborn with less than 40 weeks, recommended cefotaxime 50 milligram per kilogram. If more than 40 weeks, recommended ceftriaxone in the 50 milligram per kilogram. Next, according to American Academy of Pediatrics, early onset sepsis recommended broad spectrum antibiotics such as ampicillin, but higher dosage, and aminoglycosides, gentamicin. Late onset sepsis recommended ampicillin with gentamicin, or when late onset hospitalized, recommended vancomycin and gentamicin. Next, very important information about coagulation coagulation disorder in patient with neonatal sepsis, triangle injury in sepsis, when include inflammation, coagulation, and disorder of endothelium and cardiomyocytes. For prevention, this disorder of coagulation, recommended for treatment neonatal sepsis pentoxifylline. Pentoxifylline recommended to prevent or treat microcirculation disorder. Would dosage pentoxifylline in treatment of sepsis. Recommended dose include infusion 5 milligram per kilogram per hours continue for 6 or 12 hours. Newborn with neonatal sepsis. Supportive therapy include a respiratory problem when we include to therapy, oxygen therapy or ventilation is necessary. Cardiovascular disorder. When severe cardiovascular disorder, in this case, recommend the support blood pressure with volume expander and pressor. Hematologic disorder, treated of disseminate intravascular coagulation. Disorder of the nervous system, characterized of seizures. In this case, recommended phenobarbital. And metabolic disorder, when you reveal hyperglycemia or hypoglycemia, metabolic acidosis. I would like to introduce you with recommendation for treatment hemodynamics problems, hemodynamics disorder, patient with neonatal sepsis. In this case, recommended fluid therapy. Initial resuscitation of hypovolemic shock begin with infusion isotonic crystalloids or albumin. And we can see doses of 20 milliliter per kilogram crystalloids, and next doses may be repeated. Crystalloids as initial fluid of choice in resuscitation of sepsis and severe sepsis and septic shock. And albumin in the fluid resuscitation of the severe sepsis, septic shock, with the patient require sufficient amounts of crystalloids. Next, when you reveal a patient with septic shock or with disorder hemodynamics, in this case, recommended vasopressor. Vasopressor therapy initial to target at mean arterial pressure of 65 indexes. In this case, may be recommended norepinephrine is the first choice vasopressor, epinephrine and dobutamine. Corticosteroids. Corticosteroids we recommended only with newborn or children with refractory to catecholamine resistant shock, and when you suspect or proven adrenal insufficiency, signs of adrenal insufficiency. Only in this case recommended steroid therapy. What indicates about improvement condition patient? Initial therapeutic endpoints for resuscitation of septic shock when you reveal less indexes of capillary refill, when normalized blood pressure, normalized pulse, when warm extremities, increase urine output more than 1 milliliters per kilogram per hour, and normal mental status, and increase saturation and improve cardiac indexes. Outcomes of neonatal sepsis. You must remember about mortality. Mortality, very high mortality patient with early onset sepsis, especially in extremely preterm and preterm infants, and high in the high level of mortality patient with late onset sepsis, especially with nosocomial infection. Next, maybe after neonatal sepsis develop respiratory disorder or chronic lung disease, and prolonged hospitalization lead to the higher risk of nosocomial infection. Next, very often we can see in patients after neonatal sepsis problem of nervous system, neurologic disorder. Because in this kind patient develop intraventricular hemorrhage, periventricular accumulation. This kind patient characterize neurodevelopment impairment, and sometimes patient has cerebral palsy after severe neonatal sepsis with neonatal meningitis. Now I would like to discuss about strategies for prevention neonatal infection, neonatal sepsis. Firstly, what needed to reduce the incidence of infection in intensive care? Firstly, it's a hand hygiene practice. Next, very important, proper management of central lines. Promotion of early enteral feeding with a human milk or donor milk. And prophylaxis of lactoferrin and fluconazole. Prevention of infection associated with fungal. I would like that you know recommendation for prevention nosocomial infection, but first place we can see hand hygiene. Next, minimization use of devices. Intraventricular endotracheal tubes and lines, intravenous. Next, antiseptic and antimicrobial impregnement catheter. Today, we have a new recommendation about use this kind of catheter. Next, a very important educational program for medical staff, adequate nurse staffing, and participation in surveillance program, feedback of surveillance data. In this case, we can see how check hand after hygiene. I would like to show you in this slide one of a research where indicates different colonization Staphylococcus aureus, methicillin-resistant Staphylococcus aureus of hand before hand washing and after hand washing. It's very important for prevention of nosocomial infection. And I would like that you remember how correct prepare your hand before examining patient. And now I would like to show film about important hand hygiene for prevention infection in hospital.
The basic requirement for correct hand hygiene is the availability of the proper facilities in the healthcare workplace. Cleansing areas for the staff must be equipped with dispensers for alcohol-based hand rub disinfectants, wash lotions, and skincare products. Various types of dispensers are available. You can choose from a dispenser with an integrated dose pump in either plastic or metal. And the metal dispensers are optionally available with an extra long arm lever. Alcohol-based hand rubs are extremely effective antiseptics. An additional advantage is that they can be used almost anywhere, independent of water and sink. For example, at bedside, from a dispenser on the edge of the bed, from a pocket bottle, or at the entrance to every patient's room. This way you can disinfect your hands at any time without going out of your way. Alcohol-based disinfectants save time, are easy to use, and thus lead to a substantially increased compliance. To be fully effective in a short time, the antiseptic has to have a sufficiently high alcohol concentration. Personal hygiene includes keeping the fingernails short, clean, and well cared for. Nail polish and artificial nails cause problems in maintaining hygienic hands. They tend to become chapped or damaged, and thus encourage colonization with microorganisms. Wearing jewelry, in particular on the hands and lower arms, should be avoided at work for hygienic and safety reasons. Washing your hands, in addition to using an alcohol-based disinfectant, should be done only at the start of a shift, after using the lavatory, or when the hands are visibly dirty. In the course of a day, performing the hand disinfection without washing is fully sufficient. Additional washing would only cause the skin to dry out. Carrying out proper hand disinfection requires learning and getting into the routine of following a particular method of applying the disinfectant, a method that's established as a European norm. The goal of the 6-step method is to ensure that all surfaces of the hands are evenly covered with disinfectant and that no area of the hands is missed. Before application, the hands must be dry so that the alcohol is not diluted, which would reduce its effectiveness. First, press with your elbow to dispense the alcohol-based hand antiseptic into the cupped palm of your hand, and immediately begin to rub it in as follows. First, rub the flattened palms against one another. Then rub the backs of the hands and the spaces between the fingers by alternately pulling the fingers through those of the other hand to cover them with disinfectant. Then rub the hands palm to palm with interlaced fingers to cover and disinfect them. The amount of disinfectant required for a proper hygienic hand disinfection is 3 milliliters. Most dispensers are set to dispense 1.5 milliliters. A second pump full of disinfectant should be applied and rubbed in halfway through the required rubbing time. After this, interlock the fingers so that the fingers of one hand rub the opposing palm and vice versa. Grasp a thumb in the palm of the opposite hand and rub thoroughly with a rotating motion. Then repeat with the other thumb. Finally, move the fingertips of one hand in a circular motion in the palm of the other hand and vice versa, so that the disinfectant can get on the fingertips and under the nails. Germs, like the E. coli bacteria shown here, can only be seen with magnification, such as under a microscope. Under appropriate conditions, that is, in a warm, moist environment, they're capable of dividing and multiplying. In this animation, we illustrate, again with the example of E. coli bacteria, how the cell walls of the microorganisms are destroyed upon contact with the disinfectant. And also with this example of Staphylococcus aureus, we illustrate how the disinfection process destroys the germs and thus stops their rapid multiplication in its tracks.